What's happening, people, and welcome to this week's episode of It's All Blakademik with me, Jordan Jarrett-Bryan, your host. Another signpost to our website, blakademik.com. Go check it out, all of our podcasts. We've got some photos and all of our content from all 3 seasons so far are on our website there. And also the socials, we're across Facebook, Instagram, and Twitter as well. And as you are here, subscribe to us here on Blakademik TV on YouTube. So on this week's show, guys, I want to talk to you all about a very important topic that's come up recently, or to my knowledge anyway, the issue of the high rate of black women who die giving birth. I saw a stat a few months ago that said that up to 5 times more likely black women to die giving birth than any other women, and that just really alarmed me straight away. And I was like, whoa, that's really bad. What are the reasons behind that? And to try and help me work out what the reasons behind that stat are, I'm joined here by Mars, who is a doula. I've got Cherie here, who's a former midwife and mother of 2. I've got Natasha here, who's written about black women working within the health service. And lastly here, Georgia here, who is a mother who had a really difficult and traumatic experience giving birth to your twins. Is that correct? Georgia, let me start with you. Tell me first of all a little bit about what happened and what your experience was, and what you think were the driving forces behind the treatment that you got.
The experience that I got was constantly being reminded that I was a high-risk pregnancy because obviously I was having twins. So from the beginning, it was a constant of the control is now out of your hands. It's now, the consultant's now going to take charge of your pregnancy. I was then given appointments every 2 weeks to get scanned. And then I would have a monthly appointment with a consultant. Now, initially, the first hospital that I was attending, which I decided to move from, the consultants wouldn't even give me eye contact when they were talking to me. They would tell me that I was going to have a C-section. It wasn't a discussion. And when I told them, no, I don't want to have a cesarean unless it's for life and death or health reasons. One consultant initially told me why. Like, why would you want to do that? And I was like, obviously because the healing process, and I'm going to have 2 babies to look after. Why would I want to be cut open for no reason other than you're having twins, you're going to have cesarean? So I then changed hospitals. The hospital that I changed to are known for being specialists with twins. So it was a different, I was approached differently. I was told you can have a natural birth. As long as the first baby's in the right position, no problem, you can have a natural birth. My pregnancy was fine, no morning sickness. It was quite an easy pregnancy, but then I started having pains. In the beginning, I ignored it and I thought, okay, no, actually, let me call up the helpline and just check. They told me to come in because I was having pains in my stomach. I went in, they told me my cervix was open by 1 centimetre. I'm not going anywhere until I give birth. So I went in hospital at 26 weeks. So of course they give you drugs to try and slow it down. They, all these different scans and stuff. So it started off fine. Obviously you're anxious. I was anxious, but everything was being explained to me. I went in midweek. By Friday, a consultant came in and goes, oh, you're going home. And then I was a bit surprised. A few midwives came in and checked over me. And they were like, when I said to them, oh, the consultant told me I was going home, they were like, they were shocked as well. And actually, no, you're not going anywhere. And that was a Friday. And I did stay in. So I don't know what the midwives did, how they advocated for me, but I didn't go home. And the scary part of that is the next morning I woke up 4 centimetres dilated. So if I did go home, that would have been a whole different situation. Obviously, I gave birth naturally. I don't know in that, obviously I have no experience of childbirth before. I wasn't offered any pain relief during my birth. But obviously I know that it was an extreme case because my twins were 27 weeks at this time. The room was full of about 12 people, incubator cots, everyone's ready for them to come out. I gave birth, about 2:30, didn't see them till about 9 in the evening. Constantly getting the midwives to call up. They told me they're busy, no one's answering the phone. And my midwife was lovely. She tried to get me, initially I was in my own room. Obviously then you get moved to the ward. She said, we tried to put me in a ward with other mothers that didn't have their child because obviously I didn't have mine. Mm-hmm. And hormonally and emotionally, all I wanted to do was, I want to see them. So I didn't see them till 9 o'clock in the evening. Then got told that they're full, so one of my twins are going to have to get moved to another hospital.
Wow.
So that literally happened that night. And I then was just kind of left. Looking back, I was just in shock. Like going through it all, I didn't even know how to communicate my feelings, what I was going through. I was literally just in shock. I don't even remember, other than them telling me that one of them is going to have to be moved. I don't remember anything else they said. So by that time, I got to see them. I've never been in an intensive care unit before. So you got the beeps, you got the wires, they got the tubes. They're explaining to me everything's going on, but it's just going over my head. I'm just a mess at this point. And then it was a week. Which I've heard is actually not that bad. I've heard some twin mums have had longer periods where their twins are separated. It was a week that my girls were in 2 separate hospitals. I got discharged 2 days after giving birth. To be honest, I was ready to go because by this time, obviously, even though my initial midwife tried to keep me in a ward of women that didn't have their children, by then, obviously, women were there with their babies. I can hear, doing all that, and I didn't have mine, so I was like, okay, I'm ready to get out of here. And then I had just under a week of going back and forth between 2 hospitals because I couldn't go to one and not the other. It just didn't sit right with me.
And the general experience, do you feel you had that because what I want to explore here is how much race plays a role in the difference in treatment of women who are pregnant?
So this is the thing. When you're going through it, you never think your race has got anything to do with anything. Because all you care about is your child and yourself. Going into giving birth, I have family that have had bad experiences, so I knew about that, but I didn't know how bad the statistics are for Black women. I didn't know that at the time. So looking back, as I said, it's certain where you're treated, a certain way when you're spoken to, when you're in the neonatal, when you hear where the consultants talk at you, but then they'll have a lovely conversation with another family who are not Black, and you think, you think to yourself, is it because we're Black? But then you just put that to the back of your mind because you're concerned on your child. My partner, for example, felt that he was totally ignored. I think.
So here today, do you feel that race was a primary reason why you were treated the way you were treated?
Yes, in certain aspects, but it's hard to pinpoint. And this is what the frustrating part with this whole situation is, because there's so many contributing factors, the NHS always have something to pinpoint the issue to other than race. But the statistics are there, so what else could it be?
Okay, so Zuri, you worked at the NHS. How high up on the list of reasons, I suppose, do you think, where do you think race is on that list of reasons as to why Black women get treated differently and die at such a high proportion in comparison to other women?
I would say it's probably it'd be point number 3 rather than number 1 for me. And that's because, and this wouldn't take away anything from your experience or what you felt or the way people spoke to you, because I don't know in your individual experience, but I can think of, in my 12-year career, at least 3 other white families who went through a similar situation. And so I think that there's a lot to do with general... in our communities, we have high rates of mental illness, we have high rates of obesity, we have high rates of diabetes and things like that, which puts us at a higher risk. If you're talking about why mothers die, rather than why mothers might be treated in a different way, then I think you're going to be taking it from 2 different approaches. Also, just to say that it's not just about mothers dying in labour, it's about mothers dying in the postpartum period. Okay. So that's antenatal, labour and after delivery as well. Okay. Because in labour, I think can frighten people a bit because it's not so much about that, it's about what's happening before and after as well. Okay. So that's my personal experience. And I will preface that by saying that my career has always been in London. And so I've always worked in units where there were a lot of other Black and ethnic minority staff as midwives, including doctors as well. So I wouldn't say that racism would have necessarily been the biggest thing. I see prejudice against ourselves within the NHS and in how we treat ourselves even. But I wouldn't say it's racism as a direct cause. For me, I would say there's a lot of systematic things that will come from racism, maybe overall in the general population and culture and stuff like that. But I don't feel like that is the reason why women are dying.
Okay. Mars, let me bring you in now. First of all, can you explain to people what a doula does?
So in short, a doula is a professional birth companion. So I support families through pregnancy, labour, through the birth, and postnatally, so in the postnatal period. I'm also a birth activist, and when these stats came out from the Embrace study on the 1st of November 2018, it showed that black women are 5 times more likely to die within childbirth and the perinatal period than white women. Asian women twice as likely. Strangely, and it's something I'm looking into now, Chinese women do better than white women in the perinatal birth and postnatal period. What's scary is that 2 years ago, when I was looking at this, we were twice as likely to die as white women in childbirth. This isn't a new issue. This is something that's always been there. The research has always been there. Nobody has acted on it. The reason we're hearing about it now is because there are a lot of loudmouth black women talking about the fact that we are dying in this period. Now, the maternal mortality rates, the rates in which women die within the perinatal period, are falling. Now, that should scare everyone because they are falling, but we are rising. And you made a comment that is a very common one that I hear in this work that I do, that black women are more prone to obesity, diabetes, hypertension, etc. So let's step back a bit. When we discovered that women, if they were drinking a lot, were more likely to have smaller birth weight babies. If they were smoking, they were more likely to have lower birth weight babies. We threw information and resources into it. We trained and we taught. White women also get hypertension, diabetes, and obesity, but their rates are decreasing. Being a black healthcare professional within a white patriarchal medical system does not mean that as a black woman, as a black person experiencing birth, that your treatment will be better. Black midwives are more likely to be suspended than white midwives. But when you get to the end of the process, the white midwife is more likely to be struck off. If, as black people, we know that we can't speak without being accused of aggression and bullying, you're in the middle of a system and you're questioning the way the system works. But as soon as you step out of that path and begin to question the way the system works, well, now you're on the road to suspension. And now, if you're on the road to suspension, what happens is this: you're suspended, so you lose your reputation, you begin to lose your livelihood, and then you come back because actually you're all right, we didn't need to suspend you, you won't be struck off for this, but we're going to send you for more training and more teaching. So the ethnicity of the staff and the healthcare professionals that you're working with sadly don't seem to make that much of a difference because, as you rightly said, it's a systemic thing, it's a systemic and it's a structural thing. But modern obstetrics, so the study of maternity, the study of birth, a lot of it came off of the back of a man called James Marion Sims. James Marion Sims took enslaved women and operated on them multiple times, the same woman, multiple times with no form of analgesia. What he was doing was looking at how fistulas work and how that affects birth. So he took that study and the work that he did on these enslaved women, went to the northern part of America, worked on white women with analgesia, but his study and work has gone through and remains within medical history. We are told that constantly that black people don't feel pain in the same way. Studies and research show that doctors come to black people more slowly. We are more likely to be misdiagnosed or not diagnosed and not listened to. And in the work that I've done, the people who I see who do worse within a medical setting tend to be young black couples. You mentioned that your partner was ignored. Well, just a few months ago, I worked with a lovely young black couple and nobody spoke to the father at all. Nobody. And that was with me there, reminding them that this guy is there.
Let me bring you in, Tasha, now to talk a little bit about the kind of culture within the health service in this particular area. What are the things that you see, and do you still hear a lot of the tropes that we've just heard there from Mars about black women having a higher pain threshold, and that's maybe an answer as to why they get the treatment that they, or lack of treatment that they don't get?
Mm-hmm. Yeah,
So I come from a medical student, and at the university that I went to begin with, there was quite an emphasis on training us to be doctors who are aware of like social contexts that people are coming to. So they were interested in making sure that we were well versed in understanding societal things that are resulting in people coming to us for support. And I remember, and race came into that a lot. And after my first year, students didn't like it so much. They revolted, they campaigned to stop this education about the bigger context. So then it was removed from, so we had to have like 3-hour lectures every week, and then that got reduced to no lectures, then it got reduced to answers in a workbook that someone would check, and then it got reduced to just nothing. So then you're in a culture where people are saying, as medical students, it's not important to understand where someone is coming from. Anatomy is more important, biochemistry is more important. But like you say, what happens if a black woman comes to me and her experience of the world is very, very different to mine? Am I able to understand what she's going through? Do I have any care about what she's going through? And from a medical point of view, I've seen students, I've seen doctors who will wash their hands when a black patient comes in, but then they won't wash their hands when other patients come in.
Wow.
So you're thinking, okay, unconsciously you may have done that, but what is your thought process behind that? Or students who will laugh when a certain type of person comes in. So then it begs the question, what are the things that are taking place unconsciously or consciously that are impacting our behavior? So then, yeah, that's my...
That's interesting. Go on, sorry.
No, I was just... The frustrating thing with this whole topic is the statistics are there. And I feel that the NHS will always have a cop-out or another reason because it's health. So they can sit there and go, oh, you know, BMI, oh, hypertension. There's always something else, but at the end of the day, it is black women that are dying at a higher rate, and that needs to be investigated. I saw from the current petition that's out now, the government responded saying continuity of care is the way that they want to address this. That's all well and good, but how practical is that? Where even the midwives even going to come from?
And because if your continuity of care
is from
your
somebody
who exhibits implicit or explicit bias,
that needs to be
then
addressed.
that's the someone you have all the way through, and you're no longer listened to.
It needs to be addressed. Yes, we might have higher rates of obesity, yes, we might have higher rates of these other conditions, but the fact is that black women are dying more, so that needs to be addressed. And it's very frustrating that the NHS is not even thinking about, okay, maybe we need to address that issue. We can, you know, as you said, education for obesity, and that all can be done, but the fact is that the black women are dying, and that needs to be addressed. The race aspect needs to be addressed.
But you have to, the race aspect comes into it because of other issues. It's not just race. It's not just that we're not being listened to at all. It's not that nobody understands, because we are looking after ourselves in some situations. Like I said, I think in London it's very different from the rest of the country. But like so the two biggest killers at the moment are thrombosis, so blood clots, hemorrhage is always up there, and also suicide. So if you have a community that is already predisposed to more mental illness and they are misunderstood, underdiagnosed or not diagnosed at all, then those issues do come into it. It's not just that. In that case, I would say there is a huge race issue, but there's also a huge cultural issue, because culturally we don't tend to look after our own mental health. We don't support each other with our mental health.
I'm going to have to disagree a little, because we're living in a society that doesn't allow us to speak.
No,
and doesn't allow us to say how we are.
We don't. But, and if we do, I've been in situations where I've been in church and this young girl said, this was years ago, she said, I feel really depressed and I feel really suicidal. And the older generation were just like, just pull yourself together. You can't be talking like that. You know, you need to pray about it.
So where did that come from?
Where did that come from? No, and that's why I said at the beginning that I think that a lot of it is systemic, and it has come from, for example, if you have come from a history of slavery, if you're a slave and you're developing mental health problems, which most of them did, but you're really displaying them, you're just going to get killed. So the people around you are going to tell you to pull yourself together, and that has kind of continued. But the fact is that you can't just say, like, it's about black people. No, we have to also do more within our communities to support each other, to take our family to the GP when they're displaying mental health issues, and to encourage them to take their medication or to get whatever support they need. And I don't think that we do that enough.
So now we're moving slightly away from maternity.
No, because it's linked. Because when we're talking about black mothers,
the highest rate of maternal death, it will be suicide in postpartum, and when women go into psychosis and severe postnatal depression. But this isn't just about what we as a community do. And we have started to come to a place where we are beginning to talk and talk out loud. But when we talk, we're problematic. When we talk, we're problematic. So why do you keep talking if every time you take yourself and your issue to a GP or to a specialist, they close you down and they say, not black women, all women. So immediately you're erased and you're closed down. We come from a history where our bodies, as well as being eroticized and fetishized, have been experimented on time and time again, generation through generation. So there is an unwillingness to put our bodies into white hands. Racism, we're talking about systemic and structural racism. We cannot get away from it saying it's not just that. Of course it's not just that, but that is the founding block. That's the foundation that has started these things. So if you have a black woman who's going into labour and she's decided or been told that she has to go to hospital to have her baby, and she goes in and a doctor or a midwife just wants to look at the strange shape of her nipples, rather than supporting her in where she's at, or wants to tell her to be quiet because you're making too much noise, when she exercises agency and says, I do not want a vaginal exam, I do want to go into the birth centre, I don't want those things, and you're told to be quiet. Now, do you know what? If you're going to be troublesome, if you're going to be aggressive, I'm going to withdraw care, I'm going to change the way you're taught.
If what you're saying is correct, what can black women in particular do? They can't just accept that and continue that, oh, you know what, it's bigger than us, what can we do? What can black women do?
Well, that's why the conversation has started, and that's why the conversation keeps going. What we need to do is we need to be demanding that they do more than just hand us statistics, but they actually do something about it. And at no stage has anybody yet started to do anything about it. And the reason we're not doing anything about it is because there are three reasons why we're dying, apparently, as black women. One, our bodies are inferior to white bodies because we are more likely to suffer from hypertension, diabetes, etc. So that's the message, that our bodies are inferior, because if it was white women dying at these rates, they'd do something about it. Then it's about our lack of education, that we don't know, we don't go into the classes. There's a birth guru in America, and she said all black women need to do is pray, eat vegetables, and go into their gardens more. And the last thing is socioeconomics. Well, we know statistically that we are less likely to have money than the white communities. You look at socioeconomics is a nonsense, because you look at someone like Serena Williams, who had to argue with her nurse midwife and then with doctors before they finally looked at her and finally gave her the scan and found 3 blood clots in her lungs. Is she
an anomaly though? In that is she?
She is a wealthy, intelligent, articulate black woman. All the studies show that a poor, uneducated white woman has a better rate of survival than a black woman.
So let me just kind of pick up on the body thing. Is there scientific proof that black women's bodies, is there anything that backs up the theory that that's maybe contributing why they're dying?
Of course not. And in fact, I would say I've been taught the opposite. I've been taught that you have to be careful. When we do like study days on estimating blood loss at delivery, for example, I've been taught by white women, you have to be careful, ladies, because black women will overcompensate. Their bodies will kind of just keep going for longer, and then they will just fall, they will literally just kind of collapse. And this is the reason why you could deliver and then go back into the cotton fields or the sugarcane fields or whatever, and then collapse maybe a couple of days later, because our bodies are actually very strong. And I think that actually, if anything, I've been taught the complete opposite. It doesn't mean that we should be treated differently, but the fact is that I've been told, don't just assume that because the vital signs are normal, that woman is actually going to be normal. You need to look into like her past blood results and all kinds of stuff like that. So that's I understand what you're saying, and I don't at all discredit the history, because I think the history and the socioeconomics is important. But when you look at the statistics, they're a good starting point. If people are dying from thrombosis, then you need to educate people on how not to die from thrombosis. Because thrombosis is an issue and there are risk factors for thrombosis. And so if as an overall community we're at a higher risk of thrombosis, then as a community, yes, they need to teach us more, but also we need to be receptive to diet stuff, to exercise and all of that stuff like that.
That stuff is, as I said, I'm not saying that stuff is not a factor. But I would say if it was white women, the money would have been pumped into those things already. And those things can, with education, be changed. But I just find it a bit of a cop-out that they want to throw in poverty, they want to throw in BMI, they want to throw, without saying, just like Natasha said, the university she was in, they didn't want to know about any differences.
Yeah, and
then
terrible.
Now these doctors are where they're going to be going. They might come down to London, or they might stay in an area that's predominantly white. But if those doctors who didn't think learn about cultural differences then come down to London, they're going to have biases dealing with black people or black women. That needs to be addressed. It needs to be addressed as an institution, that we need some sort of education or some sort of training to be aware of why this is happening and to address it. I just feel like it's at the moment we're at the point where, you throw these statistics out in the air. Let's link it to poverty. Let's link it to this. Let's link it to that.
I do think it's really important to be like intersectional about how we take these things, and I don't think they necessarily have to compete with each other. So poverty is a factor, and race is included in poverty. So to say that we need something meatier as a response from you, in terms of like why we're dying more, I think it kind of like puts the problems in pigeonholes, which again is not so productive. I think it's important to be like, okay, why are we poorer? Why are we having higher rates of obesity? Why is it that we're having more blood clots? That's as much a race issue as someone turning up in a hospital and being treated in a different way to another body.
So is the answer maybe educating more black women about their rights and pushing back on things they're told? So you were told certain things.
But I think but at the end of the day, we do contribute to the cost. This is a service. Like, I know we have this attitude that, we should be grateful for the NHS. I get that. I'm grateful. I'm grateful, but we do contribute to the cost of this service. There's a section of society that are dying from the service that's being provided. So something's wrong. I'm not saying issues of poverty and things shouldn't be addressed, and they can be addressed with education, I think. But if you take that aside, black women are dying at a higher rate. As an institution, just like the police, after Stephen Lawrence had to admit that they're institutionally racist, why can't the NHS admit that something's in the institution that is wrong that we're doing, and then we're going to look at how to address that?
And we need to remember, we're talking about black women dying in the West.
Yes.
When you take the socioeconomics out of it, black women on the African continent, within the Caribbean, Asian women do better than black women over here. The studies show that if a woman is born and raised on the African continent and comes to the UK and births, her results, her outcomes are much improved. So this isn't just about racism within the maternity system. And you said that you were taught that black women, and then I was thinking, hold on. So there's this perception that this is what will happen with black women because, and then we look at history and we look at going back into the fields and being strong. We look into the society that we live at. The microaggressions start from day one. When a black woman is birthing her baby and she wants to go into a birth centre and she goes into the birth centre, she gets admitted and within 4 hours is told that she needs to come out because there's probably an obstruction. And then I go in again with a white woman who's been in the birth centre for 4 hours and now she's been in there for 8 hours and now she's been in there for 12 hours and now she's been in there for 18 hours with the exact same movement. Then there's something going on. But this is a Western issue and it doesn't start when we go into hospital to birth our babies. Yes, as a community, we need to take responsibility. But that's one of the best things I think about social media is that black voices are beginning to join together and begin to hear these things.
One of those black voices is Candice Braithwaite, who's creator of the social media campaign Make Motherhood Diverse. How powerful has that been in terms of a voice, to this issue?
It's a voice. I think it for black women that might not have been aware, it gives awareness. But I think social media activism is a bit lazy, not on her part, but just on, even if you just look at the petition, only 26,000 people have signed it. Now, if you look at the amount of people, black women, non-black women that have shared it, it should be a lot higher than that. So
That's
it brings
on us.
awareness. Yeah, it's on us. But it brings awareness, which is great. It opens a conversation. As a black woman, we're becoming more aware. I do feel that our men need to be brought into the conversation. A lot of them are not on social media. They need to be aware because most likely when you go into labour, it's your partner that's going to be with you or family member. They need to feel confident to be able to speak for you because when you're in labour, you can't speak for yourself. You're not of no right mind. You need to have a couple needs to have a conversation. He needs to know your birth plan. He needs to know what you want. So if there comes a point where he needs to stand up and go, no, something's not right here. She's saying something, she doesn't feel good. I need you to address it. We need to bring it into a holistic conversation. It's not just on black women because you're the one who's going to be giving birth. Like your partner or parent or whoever is going to be in the room with you. They need that information as well.
And what about black midwives? I mean, the treatment that comes from black midwives, is it different because they're black to black women who are going through labour and that post period, or is it the same? Is it a problem?
I just think that it's mixed. So I've worked with a lot of black midwives who've been really amazing midwives to anybody that they look after. I've worked with some black midwives who are just rude to anybody they look after. I've worked with some black midwives who I feel that if they were working with a white family, they wouldn't have spoken to her in that way.
Okay.
Yeah.
I have had an experience from a black midwife who I know for a fact because I've seen her go on to look after white midwives better in birth and pregnancy than she looked after me. And that's my experience. So
Why do you think she did that?
Because of whatever her own issues are. I can't really say, but I've seen and I've heard other midwives either go and do work experience in the Caribbean or West Africa, or they've come from that environment, and they will tell you that midwives will tell women to shut up, that they're making too much noise. One of my when I was a student, another black student had gone to the Caribbean to do work experience, and she said that she saw a midwife, it's not funny, but I just can't believe it still, that she saw a midwife actually slap a woman. A black midwife slap another black woman. And so when I'm saying that, I don't think that, don't get me wrong, I'm very much aware of our history, about how it is affecting everything about our lives now. And I think that we need to, there has to be more done by government, in the NHS, yes, but we have to look at the fact that there are reasons why these women are dying. It's not like, because the issue isn't about people getting
worse care because that woman's black and that woman's white.
Right.
But the statistics are there, though.
No, but we're talking about why women die. And so there are very specific reasons about why they've died. And there are things that have put them on a path that have brought them to death. And so in a lot of those cases, then maybe they've not been, with thrombosis, for example, the symptoms might not have been picked up very well. But my experience, and all I can tell you is my experience, is that I've looked after other people that if I, as the black midwife, didn't fight for that Asian woman or that white woman to be looked after properly and to be seen by a white doctor or an Asian doctor or a black doctor, then they wouldn't have been seen and they would have died. And this is what the midwife who's superior to me said, that if I didn't make that effort. So I think that, and these are people who are overweight or were not accessing services, even though you're calling them to come into services and trying to make appointments, there's lots of other factors. And so that's why I'm not saying that race is not an issue. Race is an issue for pretty much everything that we go through if you're in the West. Because this is not where we're from, and you have to look at how we got here in the first place.
I know.
And even if you've come from an African country and you're brought up in an African country, then most likely you've still experienced racism and how that the colonialism has impacted your society coming from there too. So it's a huge issue. But to me, when you look at the statistics and you look at why women are dying, not how they're being treated necessarily, and I know that can have an impact, obviously it has an impact, but why they are dying, there's stuff that needs to be done within communities.
They have broken those statistics down. Yeah. They have taken black women and just thrown them in together. We're not looking at whether they're West African, East African. We're not looking about where they're coming from. It's all been lumped together. When we look at the statistics, we keep saying, but who's looking at the statistics and what are they doing to change things about the statistics? They are simply bringing them out. 2 years ago, we were twice as likely to die. I do not want my daughters, I do not want my sons, if they have female partners, I do not want their babies, I do not want them to be 10 times more likely to die. Our babies are 203%
we have a right
more likely
to give birth
die.
and live.
And
I'm not saying there's not other factors that might contribute to someone dying, but there's women who would express, I'm not feeling good, I'm not feeling well, they'll ignore, then these women die. So the way that women are getting treated, black women are getting treated, comes into it. It's not something that can be pushed to one side.
So I'm going to give you the final words, the hardest question to answer of the debate. What's the answer? What do we do going forward? What needs to happen? We've got voices now talking about this, but what actually needs to happen to stop, as Mar says, that stat kind of rising?
I think we have to be intersectional in how we approach this problem. There's loads of different things that are going on. And I liked how you talked about like advocacy and the things that we're not really breaking down the stats very well. So this means we will need more scientists who care about black bodies. It means we will need more doctors who are interested in the differences. It means we will need communities who are willing to like advocate for our people. So I don't think it's going to be a one...
No. Multi-level.
And it's probably not even something that's going to be fixed in the next generation.
No, it's not.
But we need the will for that as well. And that's something that's really important. That's where social media comes in. That's where being louder. So we need to generate a will to actually make people want to make changes so that black women survive.
Ladies, thank you for your time. Thank you very much on a really, really important issue. Don't forget to subscribe to our channel here, Blakademik TV, across all of our socials, Twitter, Facebook and Instagram as well. And check out our website, blakademik.com as well. Until next time, peace. If you enjoyed that video, guys, we have plenty more content here. Go check it out and subscribe to us by clicking on the bell here. Enjoy.